pH. It has a cloud appearance. It's often combined with regular. What's our onset? 1 to 2 hours. Peak is 4 to 8 hours. And duration is 10 to 18 hours. Long acting. We talked about long acting. What does long acting mean to you?
Over
A long period of time, right? Yeah, definitely. And I told you about two. I think of the L's, right? Hannah, what are the two L's insulins? Do you remember? Which on the spot? Okay, the two L's. What are they? Huh? No. The two long-acting insulins.
the lateral.
Okay, letters. She said. You almost said.
I don't know.
Okay.
Keep going, Hannah. Keep going.
Yeah, like a
Natural.
Lantus.
Oh,
Lantus,
I
yeah.
think my boyfriend's name is Landis.
Oh, okay.
And
Does
then
any-
what's the other one?
What's the other one? Does anybody remember the other one?
Lantus and Lantus.
Levomir. Lantus and Levomir, yep. So what is long-acting? Well, it's clear, it's colorless. It gives them a constant insulin level. It's dosed once daily, or it can be dosed twice a day, so every 12 hours. We also call this basal insulin. Circle that, write that down. We call this basal insulin. Its onset is 1 to 2 hours. Peak is none. Duration is 24 hours. That's why it's called long acting. It's gonna work all day. It's gonna work all day. And then one of them is called Trujillo. I call it Trujillo. Or Trujillo, that's all I said. I was all, that's Trujillo. Like a New Mexican, right? Or Trujillo, yeah. So it's more concentrated. So long acting. Levomir or Lantus. Here's the other one. Insulin Detramir or Levomir. Its duration is dose dependent. It's lower dosing. So for Levomir, we're going to give it twice a day. And I'm going to show you how to remember this, okay? I'm going to show you how to remember it. See, this is insulin gargling. That's Lantus, okay? So the way I remember this one is I gargle with Lantus. Like I gargle with Listerine, right? That's how I have to remember it. You don't have to use it. I just tell you how I remembered it. I gargled with Lantus. And then Detramir, Levomir, the way I remembered it is that Levomir sounds like a level. There's 2 levels. I have to give it twice a day, right? Use any way you want. Because they can all run together, right? Do you agree with all these insulins? So you gotta find your way to remember them. Higher doses can be given once a day. It's also vascular, so biosimilar to insulin, U100. And then there's Trisbeca, or Trisbia. And it's ultra-acting, long-acting. So it's once daily. So again, with these medications, which one do you think is going to be more common? Levomir. And then if that doesn't work, then we start trying other medications, okay? So as we try these more uncommon medications, we know they're probably going to be more expensive, right? And hard to get. Let's go to our next question. Who can read that one for us?
The nurse has just administered the morning dose of a patient's Lispro Humalog insulin. Just after the injection, the dietary department calls to inform the patient care unit that breakfast trays will be 45 minutes late. What will the nurse do next? A. Inform the patient of the delay. B. Check the patient's blood glucose levels. C. Call the dietary department to send a tray immediately. And D. Give the patient food such as cereal and skim milk and juice.
What do y'all think? What do you want to do? You want to, gotta make sure the patient eats. Good. Fixed combinations. So to the left of the board. So 70-30, 50-50, 75-25, 50-50, and Novalox 70-30. Okay? So what is it? It consists of 2 different insulins. It's fixed, so it's exact. That's what it means, fixed. One is intermediate acting, either a rapid, so Humalog, Novolog, or a short acting type Humulin. And that's what I wrote on the board for you, just to make it a little easier for you to understand those numbers. Let's talk about a sliding scale. I'm sure you have, someone has seen in clinical a sliding scale. What's a sliding scale?
So it's based off of the current blood glucose level.
Yep.
It can be ordered,
Yep.
say per high or
Yep.
low.
So Mary, so it says it's based on the sugar, right? So when do we take that sugar? Right then and there. Very good. Very important, okay? Why is that very important? Yeah, you need a current because you're gonna dose them, right? If you say, well, that sugar was 2 hours ago, ooh, that may not be a good idea, right? It's short acting or rapid. A sliding scale could also be a standing order, right? Because it's really a protocol, right? So remember we saw it in dosage. Remember there was like a range, right? And it said from this sugar to this sugar, you're going to give this many units. You're going to give this many units. You're going to call the provider. You're going to repeat it an hour. Whatever the instructions, right? Why? Because then you don't have to keep calling the provider, right? We use this in a lot of hospitalized patients, or they're on a parenteral nutrition, so like a tube feeding, something like that. Okay. Sub-Q's ordered as an increase if their blood sugar is increasing, so it's kind of like titrate. That's what we call it. It's a titrated medication. What are the disadvantages? Delays, right? Because you have to take a blood sugar. What else do you have to do? You have to go, your tech has to go tell your nurse, right? Or in the chain, right? Then you have to go get the insulin. Then you have to draw it. Then you have to check it. Then you go give it to the patient, right? Basal bolus insulin. So this is when a patient is hospitalized. This is a medication they're gonna give. Because it needs to be at a constant state, okay? Basal insulin was what? Long acting, right? And then bolus, what's a bolus? Anybody know what a bolus is? Yes, good, yeah. So that's insulin lispro, or yes ma'am?
If you have a necrotic pancreas, would that be something that would have to come into play, like those things going together? Because it wouldn't be functioning correctly, so you'd have to.
Yes, it could be, because it depends on how many cells have been eradicated. Kind of like a kidney, right? How many nephrons have been damaged?
Okay.
And are they still producing, that's a really good question. Are they still producing insulin? Yeah, that's a really good question. Good. Sounds to me, that's an ICU thinking. I love that. Really, really good. Your patient could be really, really sick, right? And we see that. You know when we see that? Is it starting to get a little hot? And I took care of a patient who went on a run at 1 p.m. And what do you think they had at 1 p.m.? In the middle of July.
Heat stroke.
They had a heat stroke. And guess what? It hurt their organs. Yeah. So that's the question. Are they producing insulin? Are the kidneys functioning? Right? What is going on? What happened to the heart? All those questions. Very good. Very good. For type 2 diabetic, the first line medication, unless indicated, is we're going to start them on an oral medication. Okay? And so we're going to monitor their glucose levels. We're going to use one or more drugs. Remember, that's what diabetes is. It's a disease process of one or more drugs. So we're going to add a drug. We're going to change a drug. I think Joey asked earlier about, well, can they still use another drug? Yeah, because that's a great question. Because we hope not, right? We hope we can put them on one drug, and that will be enough, but it may not. And so you're going to see multiple patients on multiple drugs. We're also going to treat what? We're going to treat that high blood pressure, high cholesterol. All those things are going on with that patient. And where do these guidelines come from, or these treatments? It comes from the American Diabetes Association, okay? And they update this annually. There's an update, an addendum, okay? But it all started from the 2013. Because in that year, and several years before that, we said we need to formalize the way we treat diabetes. We need to get together. So they had a coalition. And now there's a yearly update. It's for new onset type 2 diabetes. And what does it say? When we talked about it already, we talked about lifestyle modifications. we talked about putting them on medication. And the first oral drug we're gonna put them on is metformin. We're gonna put them on metformin. And metformin is a great drug. And I know a lot of people have a really negative thought process about metformin. But I'm gonna tell you, seeing it in practice, prescribing it to patients, it's a great drug, okay? But we want these also newer drugs. We want those GLP-1s. We want those newer medications on the market because we know they lower that blood sugar. They keep it at a constant lower rate. They protect organs. So all this new medications are available for our patients. But let's talk about metformin, also known as glucophage. It's the first line. So it's the guideline says this is the first drug that we're going to start. Okay. We do not use it in type 1. Why?
Insulin.
Because they are insulin dependent. Very good. Cannot use metformin on them. Cannot use metformin on them. Because they need insulin. Okay? And these are called the guidelines. They decrease production of glucose by the liver. They decrease absorption. So you need to know that. Okay? Especially with metformin and glucoside, we're going to talk about. As an RN, you have to know that. Because if you switch it, and your patient knows, they've already Googled that before you even walked in the room. And if you told them, well, this medication can cause hypoglycemia, they're going to look at you like crazy. Because they've been on it forever. It decreases the glucose. Does anybody have candy in there? I don't need it, but who's eating? Okay, so you have candy in there? Show them your candy. Okay, show them your candy.
How much time do you need for snacks?
Yes, I love it. Okay, so her candy, I love it, okay? So she takes, a patient takes metformin, okay? And so what happens is when they eat that candy, they don't absorb all the sugar. That's why the sugar's lower. It prevents the absorption. It prevents the absorption. Do they still need to watch their diet and actually, yes. But that's why metformin is so effective. And we also use it for weight loss. We use it in pre-diabetes now. And we use it for diabetics, okay? We also use it for PCOS. Well, hold on, here's a caveat. For women who wanna get pregnant, there you go. If they wanna, that's the first question I ask my patients. Do you wanna get pregnant or not get pregnant? Because if you wanna get pregnant, I need to put you on metformin. If you don't wanna get pregnant, I can use something else, okay? It increases the glucose uptake by tissues. It does not increase insulin secretion from the pancreas. That's why it does not cause hypoglycemia. It does not. What does hypoglycemia mean? When the blood sugar goes down, it doesn't cause that because it produces. So if you don't eat nothing, there's nothing to absorb. Does that make sense? But you gotta eat, right? I was on my patients gotta eat.
Mr. Ross,
Yes, yes, ma'am.
if a patient is taking metformin and has PCOS and they get pregnant and they're wanting to get pregnant,
We gotta switch it.
they don't continue to take metformin?
No,
Okay.
remember, that was one of our questions, that's a good question, remember we have to switch right away.
Okay.
Because pregnant women, we gotta put them on insulin. Why? Marisol, why? What do we know about insulin?
It's what was the question? Sorry.
Okay, it's okay, so, as soon as they get pregnant, why do we gotta put them on insulin? What do we know about insulin?
It lowers your blood sugar.
Yeah, but it has a
It's
high
well
safety
known.
profile.
Oh, it's well.
We know, we have a lot of data on it,
Mhm.
that's what we're gonna switch.
Okay.
Gotta switch, yep. So it decreases production of glucose by the liver, it decreases absorption, increases glucose by the tissue. Oh, sorry, I'm reading it again. Hypoglycemia, gotta know that. Gotta know that. It does not cause hypoglycemia. Very important. There's some drawbacks about metformin. Okay? And I'm sure you know, because you've seen your patients. GI effects. A lot of GI effects. Okay? Until the body gets used to it. They get really bad flatulence, diarrhea, stomach upset. Everything is really inflamed, okay? You know what I tell my patients? I want you to start slow. I start at my 1 pill. Then I go to 2 pills. Then I go to 3 pills. Then I go to 4 pills. I go real slow, depending on the dose. Because if you take them all together, I'm gonna tell you, if, you know what it's called? Instant diarrhea. That's what you're gonna get. You're gonna get instant diarrhea. You're gonna get really upset because of all those GI effects. They get cramping, they get all those things. Something that we need to know about metformin, what slide is this? 38, circle this slide, this is a beautiful slide. These slides, 38, 37, 36, you need to know about metformin, because it's so common. They can cause a metallic taste because of vitamin, B vitamin, B12. So that's why in these patients, we check their B12. Because, and that makes sense, right? Because it's preventing absorption. That makes sense. Yeah, you've got to check these vitamins on these patients. Something you have to know about metformin, ready? It can cause a rare complication, and it's fatal. It's rare, and that's lactic acidosis. Need to know that about metformin. That should be on the drug card that you make. It's a rare but lethal complication. And again, it does not cause hypoglycemia. We also have second generational meds, and this is amyral glipizide or glucotrol. We're going to talk about that in a moment. It stimulates insulin secretion. So the other one is prevents absorption, but this medication actually stimulates. It stimulates, so it causes them to make it, right? Yeah, not make it, but expel it, basically. And so it increases insulin levels. So this is called the beta cell function. It improves sensitivity to insulin in tissues. And so what happens to the blood sugar? Now this is the one. What happens to the blood sugar? It's gonna go down, hypoglycemia, because it's stimulating. It's stimulating, right? And so it increases insulin. Well, what happens when you increase the insulin? Your blood sugar goes down, yeah. So this is the one the patient says what to you. When I take that glipizide, I feel what? Like, I feel dizzy, I feel nauseous, lightheaded. I feel like I'm gonna pass out. Because what? Did they check their blood sugar? Do they need to? Yes. Do they need to have a snack with them?
Yes.
Yes, right? Yeah, need to have a snack. This, remember I told you, this is my husband at 8:30 every night. I ask him, is this diabetic? Did you have, we start playing the game at 8:30. Did you have your snack? Did you have your snack? Did you have your bedtime snack? Did you have your snack? Did you have your snack? Did you have, why? What do I keep asking? What's gonna happen at 10, 11, 12, 2 in the morning? And then they're all diaphoretic, right? All sweaty, nauseated, blurred vision, can't see, all those things, right? So that's why we have to educate our patients. But we as nurses, don't we need to know about these drugs?
Yeah.
Yes, right? Because we can tell them opposite or the wrong information. Yeah, very, very important. And so what are the adverse effects? Well, hypoglycemia, but they can have nausea, they're full, heartburn, many other side effects. Right? Many other side effects. Let's move on to other drugs. The glidides. So these are very similar to sulfonylureas. Those are other drugs we talked about. It just increases insulin, okay? Very uncommon, they're very expensive. But we do see them, right? Like I tried this med on this patient, didn't work. Tried this other med on this patient, didn't work. And then we'll submit a PA, maybe we can get it approved. Yeah. They have similar effects. Headache, they're hypoglycemic, they're dizzy, they gain weight, which they hate, right? That's something that we don't like to see. We want them to what? Lose weight, yeah. Respiratory infections or flu-like symptoms. The glitazones, you'll see some of these on the market, most commonly Actos or Avandia. And this is the medications that are really expensive. Okay, so how do we get them covered? Well, they're usually a manufacturer program. And we talked about that, we call it a patient assistance program. And that's really important. If you have an indigent patient, like, and you know, they can't afford it, you can go to the website of those medications and you can help them apply to that patient assistance programs. And in some states, you can actually you can sign for it. can sign your RN and they'll accept it. And and then they send the patient, a card, and they'll get like 3 months supply for like $5, $10. They'll get a 6 month supply for $15. It really helps that patient. I try to do this with as many patients as I can. If not, I send them to Walmart. I love Walmart and Sam's because they have a $4 formulary. Walmart does, and I really like that for patients. And then they can get like 3 months for like $9, right? So that's, yeah, it's really good for patients, you know, but it has to be on their formulary. They have like a list, they'll give it to you at Walmart. And so how do we help patients, right? Very important, because remember, as registered nurses, if we don't advocate for them, no one else is gonna do it. Yeah, you have to be that person. You have to be that person. So again, these medications are insulin sensitizing drugs, so they decrease insulin resistance, they increase glucose uptake in the skeletal muscle, and they also inhibit glucose and triglyceride production in the liver. So they're activating a lot of things. Alpha glucosidase inhibitors, these can be good drugs, but they have a lot of problems. And most widely is fat flatulence. And so what is that? Lots of gas. Really bad gas. Really, really bad. I feel horrible for these patients. They have diarrhea and then they have abdominal pain. And usually when they get to that condition, we try to switch it. They're like, I just cannot hold it down any longer, okay? Again, it does not cause hypoglycemia, hyperinsulinemia, or weight gain. So that's really good. Because we don't want our patients to gain weight. That's our goal. There's Precose. That's a very common medication. It's for type 2, contraindications, adverse effects, very similar. Again, we're going from most common to least common, okay? So alpha glucosidase inhibitors. So what do? Well, they reversibly inhibit the enzyme in the small intestine. So this particular medication, again, you're not going to be tested on this one, but I just want to let you know that this one actually targets the small intestine, and that's where it works, like with the absorption. Yeah. And it must be taken with meals, so that's very important. Has to be taken with meals, and we call it first bite. That's why they have to take it with meals. If not, they're going to have those side effects. And then one of my favorites are the gliptins, and that's the DPPIB, the diphthenyl peptidase IV inhibitors. And one of them that I love, we talked about it in dosage, is Janavia. Love, love, love this drug. Because this is the one that they pee out the sugar. So it lowers that A1C. It's a great medication to lower A1C. And actually, we're actually now using this medication in kidney disease because it can prevent progression of kidney disease. So I love, love, love these drugs. Very good. There's just some caveats, right? So if you're peeing out sugar, what are we worried about?
UTI.
A UTI, very good. Yep, UTI. So what do we tell our patients? They have to drink what? Lots of water, right? Lots of water. Get that water in. Lower that caffeine, lower that alcohol. Make sure you avoid after sex. Make sure that you're using hypoallergenic products. Very important, right? Very, very important. Good. So what do? They delay breakdown of intricate, which is a hormone. So what does it do? It increases insulin synthesis and lower glucagon secretion. So it reduces fasting and postprandial glucose. So like after they eat, that's why it's so good. It reduces the fasting and after they eat. That's why it's so effective. There's some things that we need to know. They can have an upper respiratory tract infection. They have headache. They have diarrhea. They get hypoglycemic if we use it with other medications. Like what? Glipizide. Because what does glipizide do? Does glipizide lower the blood sugar? Yes. Metformin doesn't lower the blood sugar. Need to know that, you have to know that, okay? You gotta make a chart. You gotta look at your notes. Need to know that. Those are two things you need to know, you're gonna be tested on and you're gonna see it in practice. Sure, metformin does not cause hypoglycemia. Glipizide does. Have to know that, very important. Let's do a little review. What is metformin? It's a first-line medication. What is their black box warning?
Lactic acid.
Lactic acidosis, and it's a rare but fatal condition. Yeah, very good. Very good. You need to know that. Good. So we know that when we use this medication alone or with other combination drugs and diet changes and lifestyle changes, that we're gonna have better glucose control for our patients. Okay. Just some other medications that you may see, like an amylin agonist, so Similan, very uncommon. And then there's some mimetics, right? So they mimic this hormone. The only one, the ones I will talk to you about, again, they're not in your testing, but it's good for practice, is Trulicity. I'm sure you've all heard of Trulicity, right? Very common injectable. Victoza, that's the medication that I told you that it really didn't do good things for diabetes, but we saw weight loss. So they remarketed it and we see it for weight loss. And it's a daily injectable, but Ozempic is better. Jarvis is better, right? All those things are better. But it was good. I think this one, in my humble opinion, is what started everything. Because they were like, hey, we have an injectable. We're starting to see weight loss. I bet, and what hormone are we targeting? Right? All those things that we were talking about. Yeah, good. So those amylin, so it just mimics a natural hormone. It suppresses glucagon production. So what happens? They feel full. And that's why those other drugs work so well, because they feel full. Very good. Yep. It's like what we said. And so what do we see? Nausea, vomiting, headache, and weight loss. SGLT2s, these are great medications again. Let's stop here, okay? This is slide 54. We're gonna get through all of them. We're gonna finish next week, okay? Have a great day. Thank you so much.